My patients come in all sizes, shapes, and all types. I see patients in their teens up into their 90s, so pelvic floor disorders can affect anyone. Common patients tend to have multiple complaints. We find that pelvic floor disorders group together. It's not uncommon if someone comes in with prolapse that they also have bladder symptoms or bowel symptoms, and that's why we address all of them, or we try to address all of them at the time. There are many pelvic floor disorders that bother women. Probably the most common ones we see are prolapse and incontinence. Prolapse can be of the vagina, the uterus, the bowel, all presenting usually with a bulge from the vagina. Incontinence can be of urine or stool. Those are probably the majority of the patients we see, although we do see patients with other issues such as fistula, diverticulum, pelvic pain disorders, things of that sort. I diagnose pelvic floor disorders primarily through physical exam and history. So when a woman comes in, the first part is getting a complete physical exam and history, starting with urinary symptoms, sexual function symptoms, bowel symptoms, and prolapse symptoms. The next step's usually a very complicated, long physical exam, longer pelvic exam than most women are used to. It's called a POPQ exam, which stands for Pelvic Organ Prolapse Quantification Exam, which is a standardized way to be able to assess if a patient has pelvic organ prolapse or relaxation of the pelvic floor. There are other tests we can do, voiding diaries, urodynamic cystoscopy, but that really depends on the patient. As far as primary care physicians and when they should refer, I think for prolapse, the best thing a primary care physician can say to a patient is it's not dangerous. I think I've learned over the years not to use the terminology that your bladder fell, because a lot of women feel like they're touching their bladder. Indeed, they're usually touching the vagina or the uterus, and sometimes that's all it takes because they were scared they were physically touching the bladder. I'm happy to see anybody, even if it's for reassurance, but I think some patients, if they're just told what the anatomy is and it's not dangerous, they don't need to come to me at all. If they're interested in treatment, whether it be a pessary or surgery, that's when I would refer. Some primary care doctors, especially OBGYNs, do a great job with pessaries. We have an array of pessaries, probably more than the average OBGYN office, and we'd be happy to try to fit one. And of course, surgeries, we'd be happy to see the patient. For incontinence, for stress incontinence, I think it starts with talking to the patient about Kegel exercises and assessing how much this affects the patient's quality of life. If it's severely affecting their quality of life, I would refer them because one of the options is a pessary, but the real logical next step is consideration of surgery. For overactive bladder, I think most primary care doctors are pretty good these days about checking urine for blood to make sure they're not missing an infection or something else. I think they're pretty good about starting them on medications. But if the patient's not doing well with medications or even physical therapy, I think I would refer them at that point.